So that's great. Okay, so I'm actually a paediatric dietitian and I work in Glasgow. So for many of you who may not have been to Glasgow, it's a fantastic city, and 2 years ago we moved to a new children's hospital, which is now one of the largest children's hospitals in the UK, and that's up here. But Glasgow's got amazing architecture and is a city well worth visiting if you've never been. So when we think of celiac disease in paediatrics, we often think of children like this who are very wasted and malnourished, but in fact the way children present now has changed, and we don't actually see quite so many children like this anymore. We do see them occasionally, but the symptoms that children present with are much more subtle. And they often present with tiredness, maybe infections, constipation, or rectal prolapse. We see a lot of children presenting with anemia, mouth ulcers, problems with their teeth, or IBS-type symptoms. Now, we established a dietetic-led celiac service in 2007, so that's just over 10 years ago. And before we did that, we looked to see the way children presented, and this just is a snapshot of 2 time periods. So you'll see the way children present has changed over the first time period and the second time period. So we're actually seeing less children now with diarrhoea, but actually more children with abdominal pain, and a lot more children who are asymptomatic, and that tends to be children with diabetes who are screened at the time of diagnosis. So many of you will be aware of these guidelines in paediatrics were produced in 2012, looking at how we diagnose children with celiac disease, and it's divided into 2 categories: these children who are symptomatic and children that are asymptomatic. I'm not going to run through this in any detail because of time, but essentially children who are symptomatic who present with positive serology need to be investigated further, and actually if their serology is high enough with positive HLA typing, they may not need a biopsy. So this was a big step forward, and it took us a little while to adopt these guidelines within paediatrics, but we looked at our patients who had previously been diagnosed with biopsies, and many of them fitted into the category of these. There's also another algorithm for patients who are asymptomatic. So this tends to be children who have got other associated conditions such as diabetes, and those with positive serology, and they essentially all would require a biopsy. So the benefits of the new guidelines are that not all children now need a biopsy. In our centre, we adopted these guidelines in 2013. It means a more timely diagnosis, so we looked at how much time we've actually saved without referring children for a biopsy, and it's actually 6 to 8 weeks, so it means they can get started on the diet sooner. So it's a more timely diagnosis. It's actually got lots of cost savings because they're not going for a general anaesthetic, they're getting diagnosed in serology, they're not coming to day surgery, and they're not needing pathology. So there is a big cost saving as well, diagnosing with a biopsy. So the background to establishing this service was we had a very uncoordinated service. So this was run by clinicians. There were no protocols or pathways in place. We had a very basic database, which is really the numbers of patients we had with celiac disease. And I was a dietitian who worked in gastroenterology, but I also covered CF. So we had lots of different clinical conditions, and I'm sure many dietitians will be sympathetic to the amount of work we've got. So we had very inadequate dietetic support. So the celiac patients were managed by 4 consultant gastroenterologists. There was myself. These patients came to just a general gastroenterology clinic, so there was actually no adequate dietetic support. The consultants all did different things. The frequency of which the reviewed patients was different. The bloods that they ordered was different, and the way they reported back the bloods to the families was all different. So there was no consistent approach. If we had somebody that was diagnosed with celiac disease, they would be seen out with a clinic. There was no clinic cover if I was on leave, so often these patients that were only coming annually might not have been seen for a couple of years. But before we established the service, we wanted to know whether patients would actually engage with the service, which was run by a dietitian, where they may actually not see a doctor at all. Okay, patients were actually really positive about it, and we wanted to know that before we actually started doing it. So the proposal was that the dietitians would manage all these patients. So this was taking us a bit out of our comfort zone. It was making us work at an advanced level. So we would see them from initial referral, and we'd be involved in their diagnosis, and we'd follow them right through. If there was any complex patients, of which there are a few, they would still attend a GI clinic. But of course, to take this on board, it was going to need additional funding, so we did a business case. We initially established a clinic once a fortnight, and we were going to provide education at clinics, and we're very lucky within paediatric gastroenterology. We've got our data manager, and she set up a very comprehensive database so we could capture lots of data for this service. So we managed to get funding. One of the other issues is always trying to find a clinic space that you can get regularly. So these are just practical things. And there was a lot of work setting up clinic. We had to get agreement from everybody. And we had to get agreement from biochemistry and haematology to allow the dietitians to order bloods. We had to get agreement from the outpatient staff because the patients had to be weighed and measured and also had to have bloods taken. And all the consultants had to agree. So actually we had a very forward-thinking consultant gastroenterologist, Pori Grogan, at that time, who was very proactive in helping us to drive this forward. And he could see that if the dietitians took this on, it would actually save them lots of clinic space, and we were taking on a role that they were essentially doing. We had to have accessibility to medical staff. However, if there was a problem, that was agreed. So we did a business plan. We got an additional dietitian, but of course you always underestimate how much time you're going to spend. So actually, on retrospect, we should probably have asked for more hours. We wanted to do a competency framework because this was taking us to a different level of work, and we did a competency framework along with the gastroenterologists. We developed protocols and pathways for running the clinic, and we developed a really comprehensive database. So we did patient peer consultation, and patients were very keen that we took this on board. I think they could see that it was going to be a much more comprehensive service. They were going to get better reviews. It was a much more streamlined service, and we set this up in 2007. We agreed to pathways and protocols, and as I said, it was an advanced role. So we did a lot of education and training within the gastroenterology department. We developed a competency framework. We get an annual assessment from the clinical lead, so he sits in with the dietitians at clinics and makes sure we're doing everything correctly. He looks at all our paperwork. And we have 6 weekly meetings with our lead clinician, who at the moment is Professor Richard Russell. We go through all the patients who have been referred, who come to the clinic. We review their bloods. If there's any odd things, we would bring them up at that meeting. And it's also a bit of an education for us as well. So who comes to the clinic? Well, we see patients with positive serology, with or without symptoms, or if there's a strong family history of celiac disease, with positive serology. We see the diabetics with positive serology, and patients with dermatitis herpetiformis. So this is a bit of a complicated pathway. So the referral essentially comes in. We're so well established now that often we get direct referrals, so from GPs, other consultants within our health board. So often the referrals would come to myself for children suspected of celiac disease. They get an appointment at our clinic, and we repeat we've got a blood set that we repeat. The important thing is we can assess how much gluten they're actually having, because that's a thing that often happened in the past. Patients were being referred straight for endoscopy without anybody looking to see actually whether they're getting enough gluten at that time. If children get referred for a biopsy, then we would have a look at the path along with our lead clinician. That gets signed off, and we would inform the families that the diagnosis has been made. We bring them back to our clinic, and then they get followed up. We developed lots of literature as part of this service, so we've got literature telling patients what the clinic's about. We've got an endoscopy leaflet, we've done a screening leaflet, we've done an HLA typing leaflet, so these relevant leaflets can be given to the families. We've got pro formas that we fill in at clinic, looking at symptomatology, growth details, the bloods that we do. If anything's got a red flag, that's a thing we've got to be highlighting to consultants if they've got, say, blood in their stools, because some of the kids may actually need an upper and lower endoscopy if that's necessary. So at our clinic, we see new potential referrals and also new children who've been diagnosed. We see them again once they've been diagnosed at 3 months, at 6 months, and then annually. And at that clinic appointment, we do a clinical assessment. We do blood monitoring. If we're concerned about the patient, we bring them back sooner. There's validated tools for pubertal status in children that we use in our IBD service, and we've taken that to our celiac service. We also run telephone clinics within our service, and patients can get access to that. And we also have a generic email address that we give to patients so they can contact us directly. So one of the, I suppose, important things is always securing the diagnosis in the first place and ensuring adequate gluten. And we can do that in their first appointment. Unfortunately, we still see some children who, when the GP's done bloods because they're suspecting celiac disease and there's a mention of celiac disease, the family withdraw gluten from their diet. So that we still see that. In fact, some of our clinicians within our hospital still do that too. So one of the important things at our clinic appointment is we can ensure they're having adequate gluten. We do their IgA TTGs, or if they're IgA deficient, we do IgG TTGs and EMAs. We do HLA typing, but we always offer the option of a biopsy for all patients. Now, I think out of all the patients we've seen, only 1 or 2 families have opted for that if the child can be diagnosed in serology. So parents would rather the child didn't go through a general anaesthetic and they were diagnosed in serology. We offer a biopsy in all patients under 2 years. So we get the diagnosis and we always confirm that in writing with the family so that they've got that in detail. We've got a pro forma for those children who get biopsied so that the MARS scoring is signed off, and that's signed off by a clinician. So when the patients we would phone them up and give them the diagnosis, and because we've already met the family, so we actually know them. So we'd see them within 1 to 2 weeks of their diagnosis. We see the patient and the relevant family members. If we need an interpreter, we can organise that, and we always give the families a 1-hour slot for teaching them regarding the diet. So within Scotland, you've heard of SBGAN and BISGAN. Well, in Scotland, we get SBGAN, so that's the Scottish Society of Paediatric Gastroenterology, Hepatology and Nutrition. And within that group, there's a number of dietitians, the paediatric dietitians, and as a group, we've agreed what information is basic that these patients should have. So we have like celiac packs for children, for the families, and that is Scottish-wide for paediatrics. That's been agreed. So we always give them a guide to gluten-free living, which is the diet sheet. We give them starter packs from the companies. And I understand the prescription things are a bit different in England than they are in Scotland. So, but even within Scotland, they're a bit different between areas of Scotland. So Edinburgh is very mean and they don't have very many things in prescription, whereas Glasgow is much more generous, and we have got quite a range of things on prescription. And we always advise families to join Coeliac UK. We give them information about our clinic, we give them information about family screening, and we always give them contact details. We've got business cards that we give to the families, and they're very good at contacting us, but we always do a 2-week phone review once they've been diagnosed, just as a check-up. We give them all the information about all the huge range of foods that's available in the supermarkets, and there's so much information, more information out there. I've been working as a dietitian for a long time, and the amount of information and the amount of products that's available has hugely changed in all that time. It's much easier to be gluten-free now than it was even 5 or 10 years ago in the UK. So as I said, we do a follow-up appointment at our telephone clinic within 2 weeks. Families can contact us with our generic email. We review them at clinic at 3, 6 months and annually. We always, when we do bloods, we always write back to the families. That's part of our pathway, so they always know if we're worried about them, we bring them back sooner. So what do we do at clinics? We always review how they're growing. We review the symptoms. We review what they think, how compliant they are, as opposed to what we think they are. You know, quite often families will think they're being compliant, but when you sort of delve into it a bit more deeply, they're not being so compliant. We would do bloods at 6 months and then annually. We always ask them if they belong to Coeliac UK, what they're using, what do they get in prescription, how are things going at school and nursery, because that can often be a downfall. They're not getting suitable foods there. I suppose one of the challenging things is when you transition these children to adult services, and I think within paediatrics we've got a very tight group in these children, but when they go to adults things change a bit. We always start discussing transition from about 14 years old, we tend to transition children when they're 16. We try and see patients on their own, and we encourage independence, getting their own prescriptions, but the model of care in adults is very different. And certainly they tend to get referred to a gastroenterologist and a dietitian. If they're within our paediatric service, they only tend to get followed up by a dietitian until they're 19. And then in Scotland, if patients join the gluten-free scheme, they're registered with the pharmacy, and then they get an annual review with the pharmacist. So that just doesn't seem right to me. After looking after these young people so well for such a long time, when they get to adults, I'm not sure quite what happens. And I know we're doing a lot of work in Scotland to try to improve all that. This is just part of our database that we've developed. So we collect information from who refers the patients, how they got referred, what symptoms they had when they were referred, what bloods were done, what all their blood results were, what their growth's like, if they had a biopsy, what the path was. So this has been really good for audit purposes. So we've got a very comprehensive database. And this was just a couple of the posters we did last year about changes in presentations, and that was all stuff pulled from our database, and the length of time to TTG levels to normalise. We've done that as well. So one of the things we were interested in knowing about how patients wanted to be taught. Two of my staff went off on maternity leave, so it left us a bit of a quandary about how we were going to still run a service. One of the things we did was we wanted to see whether families would like group education. So we did a questionnaire to see, would you like some group education rather than seeing patients individually? But actually they came back and said, we would like group education, but actually we want to be seen as a one-to-one. So that didn't really work for us. We thought it would be a good idea. We have done lots of professional educational days for families, along with Coeliac UK, and we've done some professional days as well. We've just recently produced some YouTube videos that families can access, and these have just come out a couple of weeks ago. So these are all dietitians that have done this, okay? So these are people that work with me, and we've done this so that families can access these YouTube videos before they come to clinic, so they've got a background. Because essentially you're telling most families the same basic information, but you can tailor that to each family when they come back to clinic. So that's something new we've developed. We also want to make sure that patients are happy, and also people referring into the service are happy. So we presented this at Buchanan a few years ago, looking at patient and clinician satisfaction. So really we got really positive feedback. Most of the patients thought it was an excellent or very good service, and again, the people who were referring into the service were very positive about it as well. So it has become quite a high profile service now. We currently manage, when we started the service, we had about 60 celiac patients that we knew about. We've now got over 275, so the amount of patients we're seeing has gone up and up. We now get 1 to 2 new referrals each week for potential celiacs. We've had to increase the number of clinics we do, so we used to have 1 clinic once a fortnight when we started. We now do 2 clinics weekly, and we have 3 new patient slots and 9 follow-up appointments. I would say the engagement, I had a look at the DNA rates. The DNA rates are very, very low in the service. Patients are really engaged. If patients DNA, we send them another appointment. If they DNA that appointment, we send them a letter encouraging that we might have to engage social work to help them get to an appointment, because we don't want to leave these lose these patients. And in fact, we haven't lost any patients to follow up. So I think that just shows how engaged patients have been with the service. One of the challenges has been we've actually identified a lot of parents with celiac disease. So parents come along, you ask them a bit about their history, and they say, I've got IBS. And we say, oh, well, I think maybe you should go and get screened. And that does happen. So we've identified quite a lot of parents who've got celiac disease, and also we've identified quite a lot of siblings. So when we get them screened, they've come back. We've actually got one family that's got triplets, which is actually a nightmare at clinic, because they all look pretty much the same, but trying to get a clinical history between the 3 of them is really difficult. We've got a couple of sets of twins. With our blood monitoring, we've actually identified 3 patients with autoimmune hepatitis. They've been picked up in abnormal liver screening when we've done that. We've picked up quite a few children with abnormal thyroid function tests. We've got a very large cohort of IBD patients, and we've actually got 4 patients with Crohn's disease and celiac disease that we manage as well. So these patients would come back to a gastroenterology clinic as well. The other group I hadn't really talked about are the diabetics. So we haven't got a huge number of diabetics. We've had, they are managed within the diabetic service, because initially we brought them to our celiac service, but in fact the patients didn't really engage with coming to 2 chronic clinics. So we've upskilled the dietitians who work within the diabetic service, and they do the same blood monitoring things within that service. So in summary, this has been an advanced role for dietitians. We've taken on work that clinicians would usually have done by taking the service forward. I think it's been really fantastic for dietitians because it's really raised our profile within the hospital, and I've been lucky enough to present this work at quite a lot of meetings in Europe as well. I think because within Scotland all the paediatric dietitians tend to know one another because we're quite small and a kind of unique setup, it's improved quality of care across because we're all giving them the same information. It's given us a sense of professional autonomy, and I think, you know, when we started off it was a unique service, but lots of other trusts have adopted similar models of care. So thank you.